controls. We are basically discussing a number of things today, and we have a number of presenters today having this echo session, which is in regards to navigating clients through prostate cancer screening, diagnosis, and staging for access to treatment. So my name is Sam Mbunya. I'm a advocacy relations consultant with the Indiana Hemophilia and Thrombosis Center, and also a steering committee member for the Africa Cancer Research and Control ECHO program. So yes, I think I see Dr. Makipunda. Karibu sana, welcome. Great. Right, so I think we'll just do a round of introductions. I've mentioned within just about a couple of minutes, just to get to know each other. So I'll just call out some names, just mention who you are and what you do and where you're based. And then we'll probably kick off in the next couple of minutes. So I'll just call on a few people. We'll start with Martin Omondi.
Good afternoon, everybody. I'm Martin Omondi,
Yes.
Access Mobilization Assistant at KENCO.
Thank you, Martin. Thank you for joining in. Mishka Kohli.
Greetings, everybody. Apologies, I'm in transit, so I have my camera off. My name is Mishka Kohli Syria. I'm at the Center for Global Health at the National Cancer Institute and a member of the steering committee. Great to see everyone.
Thank you, Mishka. John Black.
Hi, I was trying to get my video on. Good afternoon, the team on the east side, and good morning, those who are on the other side of the pond. My name is John Black Kabuche. I am a medical doctor and a researcher in digital health at the Uganda Cancer Institute and at Stockholm University in Sweden. Also a member of the steering committee, and I'm very happy to be here and to see you all joining.
Perfect. Thank you, John Black. Ruth Manda. Okay, maybe they're not in a position to unmute. Okay, Caroline Tinyari. I think we'll just do this one more and then we begin.
Hi, everyone. My name is Karen Tinyari. I work with Kenyan Network of Cancer Organizations.
Thank you, Caroline. One more, I think Sydney Chahonyo. Okay, probably not in a position. Terry Mwanzi.
Good afternoon, everyone. My name is Terry Mwanzi, Breast Cancer Kenya. Thank you.
Thank you, Terry. All right. I think everybody else, if I haven't mentioned your name, not a worry. Please feel free to just introduce yourself in the chat box. Just a few reminders. You could mute your microphone if you're not speaking, and then if you have very good bandwidth, please make sure to turn on your video. It basically makes our sessions more interactive, and then of course using the chat box at any time to introduce yourself, as mentioned, ask questions, and make any comments. Enable subtitles on your screen as needed if you have that option. And lastly, these sessions are recorded and they'll be shared with you. So we have our session's objectives today. And as mentioned, the session will be talking about navigating clients through prostate cancer screening, diagnosis, and staging for access to treatment. So the objectives are, how patients navigate into the system, including overcoming barriers and stigma. And what we would like to do today is to discuss the benefits of having a prostate cancer navigation program, discuss basic steps of setting up a successful basic navigation program, and to discuss how to link community and facility navigation programs and things to consider. So I will introduce our first case presenter. And so we have Dr. Laila Mwakipunda. She's a dedicated oncologist resident at University of Muhimbili of Health and Allied Sciences in Tanzania. And she's on the verge of graduating. And her passion lies in advancing cancer care with specific interest in genitourinary, gynecology, and breast cancer. So she has a dissertation which was centered on biochemical response and overall survival among castrate-resistant prostate cancer patients. And she firmly believes in addressing healthcare disparities in Africa through cancer research. In 2018-2019, she actively participated in 3 large prevention and awareness campaigns in Northeast Tanzania, Kilimanjaro, and Arusha specifically. And during these campaigns, she and the team successfully screened women for breast and cervical cancer and provided prostate cancer screenings for men. She's poised to make meaningful contributions to the field of oncology upon her graduation. And then also we have a didactic presenter, Dr. Nosifo Zulu. She herself is a patient navigator, project coordinator with the Cancer Association of South Africa, Cancer in South Africa. So she currently has a Bachelor of Arts degree in social work and currently pursuing her Master of Arts in Public Health. All right, so we will have Dr. Mwakipunda present her case presentation. Just a second, Dr. Mwakipunda, I will be getting your case presentation on. Just to confirm, you're still there, Dr. Mwakipunda?
Yes, hello, I'm still here. Thank you for the warm welcome.
Sounds good. Just a second. I'm just trying to get. So can you confirm that you can see the screen?
Yes, I can see clearly.
Great. So just let me know by mentioning next slide, and I'll be able to change the slide for you.
Okay, thank you very much. I'm delighted to present to you 2 cases of prostate cancer who were diagnosed through cancer screening outreach in Tanzania. Next slide, please. The first case is a 69-year-old male from Mtwara, which is southern part of Tanzania. He's a peasant and he had a diagnosis of metastatic prostate cancer. The history of presenting illness is that the whole of 2021, the patient had lower urinary tract symptoms. In January 2022, he underwent transurethral prostate resection at the health facility following cancer screening outreach. No further investigation or treatment. 2023, he presented at Ocean Road Cancer Institute, which is the National Cancer Institute in Dar es Salaam, Tanzania, with a progressive left shoulder pain. In terms of his past medical history, he has hypertension, which was medically controlled. The next slide. Upon his clinical workup, which was in May 2023, this patient presented with a good performance status of 2, having the baseline prostate-specific antigen, which was 50 nonogram per mil. And they decided to do a left humerus X-ray, and it was suggestive of metastasis. Following that, they decided to do a bone biopsy, which showed metastatic adenocarcinoma, and they queried more likely the primary was from the prostate cancer. And further, this patient also did a CT scan of the spine, which showed widespread skeletal metastases. And as well, he did the chest, which unfortunately also showed pleural effusion. As well, he did an MRI of abdomen and pelvis, which showed the remnant of prostatic tumor infiltrating the posterior urinary bladder wall, as well as seminal vesicles. And they also noted he had widespread osseous metastatic lesions without spinal cord compression. The next slide. When it comes to his treatment and follow-up, in May 2023, this patient was initiated on total androgen blockade, which is gorseline, 10.8 milligram sub-Q every 3 months, as well as bicalutamide, which was taken orally, 50 milligram daily. And as well, he was initiated on zoledronic acid in order to prevent his skeletal-related events. And this medication received as well every 3 months. And the patient was scheduled for physical exam, PSA assessment, and imaging after every 3 months. Unfortunately, this patient is lost to follow-up since May 2023. The next slide. We have our second case. Is a 65-year-old male from Kilimanjaro, which is the northern part of Tanzania. He's a peasant as well. He has the diagnosis of prostate adenocarcinoma, having the Gleason score of 7, and he was stratified as regional risk group. His history of presenting illness as well, he had a lower urinary tract. This was 18 months prior he was discovered during the Ocean Road Cancer Institute outreach campaign, which was conducted on 13th November 2021. And at that time, they did the PSA rapid test, and it was positive. In terms of past medical record, this patient has no comorbidities. The next slide. When it comes to his workup, which he did from December 2021 through January 2022, his performance status was 1, having the baseline PSA, which was highly elevated, 120 nanogram per mil. Upon digital rectal examination, I had a hard prostate, asymmetrical, not nodulated, medial sulcus was also not obliterated. And his histology was proven to be prostate adenocarcinoma, having the Gleason score of 7. And further, they did pelvis MRI in order to delineate the primary, and it showed prostate enlarged with breaching of prostate capsule, seminal vesicles, and iliac lymph node were also involved. He also did a staging chest, abdomen, and pelvis CT scan, which showed the same finding as MRI. With good news, he didn't have distant metastases. And as well, they did a bone scan, which showed no skeletal metastases. And so far, this patient was staged as T3N1 and not, which is regional prostate cancer according to the NCCN risk stratification. The next slide, please. In terms of his treatment and follow-up, the patient was treated with external beam radiotherapy to the pelvis from 14th of February 2022 to April 2022. He received as well, concurrent with gorseline 10.8, excuse me, there is a typo. That has to be milligram sub-Q, whereby he had a good tolerance of that treatment. Upon his second follow-up visit, which was May this year, his PSA levels, they dropped up to 0.924 nanogram per mil. This last visit is actually 2 days ago, where he's still on hormonal treatment with botulinum and bicalutamide. He's faring well with an on and off complaint of hot flashes because of the hormonal treatment, and disease has remained stable with the latest PSA of 0.03 nanogram per mil. The next slide, please. Before I go to the Tanzanian national guideline for prostate cancer screening, I decided to present these two cases because both of them, they were diagnosed during the screening program, which is a good thing. But from what we have seen from the first case, this patient apparently, due to program, but after having his surgery, he didn't know where to go. Maybe there was further investigation he was supposed to do, of which he was supposed to do. So he was lost to follow up. And the second patient as well, we can see also was doing outreach, which is a good thing. Till today, the disease is controlled. So thanks to that. And so the message is that navigation, I believe that navigation starts from the awareness campaigns. If the patient, they have this awareness of prostate cancer, and also the navigation program is there to follow up these patients since from the awareness, screening, and treatment, I believe even the first might not have ended up to being a metastatic disease. So in Tanzania, we have a cancer screening program, prostate cancer screening program, whereby the guideline actually, they recommend that screening is not recommended, but if it's done, we begin with the PSA and digital rectal examination. And this screening starts at the age of 50, whereby this patient should have a life expectancy more than 10 years. Screening of high-risk group, these are the patients who have first or second degree relative with prostate cancer or ovarian cancer or pancreas cancer, or even the men with breast cancer as well. These patients are in a group of high risk, so their screening should start at the age of 45 years. The next slide, please. So there are institute-based screening. So far, I managed to get the two large institutes in Tanzania, whereby Ocean Road Cancer Institute, which is the National Cancer Institute, as I said earlier, whereby the guideline is that they do a rapid PSA test upon screening. And if it's positive, the patient undergo quantitative PSA, which is followed up by urology consultation. Because at Ocean Road, there's no other medical departments, so it's only purely cancer, so they have to refer patients to urology. At Kilimanjaro, whereby the urologists are there on site, the patient, they can do straight away quantitative PSA and digital rectal examination. The next slide, please. And this is my last slide, highlighting the challenges what we have here in Tanzania. So far, we don't have navigation program, and having this unavailability of this program can lead to delayed or fragmented care, as we saw at the first case. In terms of delayed, we can see both patients, they had symptoms more than a year, they didn't attend any hospital. So it means there was delayed treatment, and this is because of unavailability of navigation program. And the second challenge, which is large, is that late presentation is very common, as I said, due to lack of awareness in the community. And another challenge is that high number of defaulters or lost to follow-up. This can be due to culture. Most of them, they don't accept maybe modern medicine, despite having the awareness or undergoing screening. At some point, they default treatment. This could be due to culture or faith belief. Yeah, thank you very much. The next slide. Then that's marked the end of my presentation.
Thank you, Dr. Mwakipunda, for your presentation. Yes, I think you have highlighted your cases, and we'll probably have to see a way forward on it during the Q&A section. But if the team, obviously the hub and the spoke sites may be able to just write a comment on the chat box as well. And as you think around the questions for Dr. Mwakipunda and see a way forward for these patients, will be highly appreciated. So I think other than that, we can move on to the didactic session. Dr. Nosifo Zulu, are you here?
Yes, I'm here.
Okay, thank you, Dr. Zulu. Would you like me to project your presentation, or you have it with you?
Yes, please.
Okay,
Please
so
project.
I project it for you. Okay, no problem. Okay, I think this is in order. Just give me a moment. I should be able to be on board. Okay, how does that look? Are you able to see the screen?
Yes, I am. Thank you.
Thank you. Just let me know by mentioning change slide. I'll be able to do that for you. Thank you.
No problem. So today I'll be sharing about the prostate cancer patient navigation project that we previously ran, and the one that we are about to implement in KZN Durban. Next slide, please. Next slide, please. So just to give you some background information, the Cancer Association of South Africa, which is known by Cancer, is a non-profit leader in the fight against cancer since 1931. We enable research, educate the public, and advocate for and support all people affected by cancer while leading South Africa towards a cancer-free society. Patient navigation in cancer care refers to individual assistance offered to patients, families, and caregivers to help overcome healthcare system barriers and facilitate timely access to quality medical and psychosocial care. Patient navigation works with patients from pre-diagnosis phases of the cancer experience. Next slide, please. So Cancer previously ran a successful prostate cancer navigation project in 2013, which ended when our funders pulled out due to a change in their funding strategy. With the support of the ACS, which is the American Cancer Society, we are now planning a second patient navigation project, which will build on the successes of the first project, as well as address some of the problems related to prostate cancer diagnosis and treatment raised in a recent research paper by Dr. Singh in Durban, South Africa. The goal of the new project is to reduce late diagnosis and prostate cancer-related deaths, as well as challenges that patients encounter during screening, treatment, and post-surveillance and follow-up. Next slide, please. The benefits of the prostate cancer patient navigation project were or will be to increase community awareness about cancer, its causes, the symptoms, and screening methods, to improve in early detection of prostate cancer through regular screening drives, emotional and practical support for cancer patients, their loved ones, throughout the process from screening to treatments and beyond, a reduction in deaths due to late diagnosis of prostate cancer. Next slide, please. So the first thing one would need to consider when setting up a patient navigation project or program is to conduct a needs assessment. Depending on the country or the facility that you are approaching, you may need ethical approval, research ethical approval to do it. Also because of certain acts, like the POPI Act, which is Protection of Personal Information Act, applies in South Africa. So you need to follow those guidelines. One, you need to speak to male community members about their knowledge of prostate cancer and the importance of early detection. Speak to current prostate cancer patients about their experiences from diagnosis to date to identify potential barriers and challenges in the process. Evaluate research that has been conducted on prostate cancer screening, diagnosis, and treatments in target area. The second point would be to identify the points in the process at which navigation type interventions would be required to alleviate the challenges and design a project around this. The types of barriers or challenges that were identified in our previous projects and through our current research includes, next slide, please. The patient factors were lack of personal health awareness, only seeking medical intervention when systematic or traditional medicine fails, financial difficulties prevent patients from keeping medical appointments due to transport costs. When it came to the healthcare providers that were interviewed, the factors were inadequate knowledge of DRE, PCA, when to appropriately refer, belief that prostate cancer progresses slowly and does not need urgent attention. Next slide, please. We found that the factors related to infrastructure were lack of dedicated prostate biopsy clinics, lack of equipment, which is ultrasound machines with retinal probes and biopsy needles, overbooked clinics, lengthy pathology process, inadequate human resource training and allocation. We found that these factors were not only linked to the facility or the hospital we had initially hoped to work in, but it was also linked to the community, which is why our patient navigation covers both the community aspects and the facility aspects. The third point would be to meet with stakeholders to share your needs assessment findings and your detailed project plan, ensure buy-in and support for the project. In our case, we needed to get approval from, next slide, please, the National and Provincial Departments of Health, hospital management of the targeted hospitals, oncology staff of the targeted hospitals, staff in the local clinics serving communities we are targeting, community leaders of relevant communities. The fourth point would be to implement the project Ideally, navigators should be selected from the local community as they're already aware of the resources that are available. And also they are a familiar face within the community. Navigators need to be trained in terms of prostate cancer, causes, screening, symptoms, diagnosis, staging, treatment, and side effects. And also in terms of the resources and support that the organization has available to assist patients. In our case, it's telecounseling, support group information. We also have a care home that houses or accommodates patients during their radiation treatment. To qualify to be booked into our care home, you need to at least live 50 kilometers away from the treatment center to ensure that the patients do not default the treatment. Next slide, please. Navigators would need to go into the community and do talks if there are men that are 35 plus that present with signs and symptoms. They would be referred to cancer screening drives and local clinics for PCA blood tests to be done. This is also where the linkage comes in. With our Department of Health, they also have community outreach programs, projects, as well as events. So the navigators will then start within the community, within the programs such as Isibaya Samadoda, whereby it's a community meeting for men, where men discuss their health issues and any general issues that are male related. If screening results show abnormality, the community navigators guides clients through the health system, first to the district hospital, and then the tertiary hospital, equip them with prostate cancer related information. When a patient arrives at the tertiary hospital, the patient is referred to our hospital navigators that assist them find their way to all various departments for blood tests, x-rays, treatments, and so on. Referrals to cancer, telephone counseling, support groups, and other resources, such as temporary accommodation in our care home, also takes place. Next slide, please. The fifth point would be to continuously monitor and evaluate the project. This allows for ongoing improvements. It also facilitates reporting to all stakeholders. It also assists when you are planning to apply for funding. So you have something solid to present to the potential funder. Next slide, please. I'd like to thank you. I think I'm done. And Cancer hopes that you will join the fight against cancer and make a difference in people's lives. Thank you.
Okay, thank you, Dr. Zulu, for your presentation. And also highlighting to us the work that you're doing in South Africa in terms of patient navigation through the Cancer Association of South Africa. So this is the moment where we open up discussion for the case presentation and also any questions regarding the didactic presentation, which has been presented by Dr. Zulu. So we'll just have a couple of minutes to absorb, both presentations. And also, of course, I have already seen a question here at the chat box for Dr. Mwakipunda. So this just goes out to you if you could, have an answer for it. So what did you mean by saying Tanzania has no navigation programs, or you meant that there was no demand creation activities on different cancer screenings? in the country for the communities. Maybe you can expound a bit more on that. Sorry, you're on mute. Yes.
So I made a little research by asking. We have a cancer screening unit at the National Cancer Hospital, which is Ocean Road, and also in Kilimanjaro, Christian Medical Center. They also have oncology unit, and other hospital like other two hospitals in the country. I asked about it. That was just verbal, and also according to the experience, is that we have outreach program of screening where they screen patient, but the follow-up from there is we don't have that program of following up patient. So the only thing that they do is for example, for prostate cancer screening, they do the rapid test, and if it's positive, they take blood to the respective center. And if the results are positive, is when they call the patient. If the patient number is unreachable, there's no follow-up after then. And if they call the patient that you need to attend as a cancer hospital or for further evaluation, there's no follow-up that this patient, they actually attended a respective unit. So there's no actually, navigation like to follow up patient from the awareness campaign during the screening to follow them up with the attended, and so the whole chain there of navigation program is not there. That's what I meant.
Thank you, Dr. Mwakipunda. I think, yeah, just to follow up on that as a general question, and probably from the case presentation that you did from the first case, is just an example to know a way forward for for this patient who was lost to follow up since May, and how would you go about patients who are lost to follow up, and also if you have any examples of patients who were lost to follow up and then you actually found a way to get them back for treatment, and does that, of course, create a negative impact when it comes to patient care, and also access to their medicines while they were, in quotes, lost to follow up. They were lost. So what has been the impact so far? And of course, in regards to this particular patient, what would be the way forward? Do we just let them go and hope that they come back to the facility, or is there a retrospective way to also just find out where they are through their family members or any other records that are within the facility?
Mm-hmm. Yeah, so the challenge is actually huge since it's a prostate presentation. So I was just focusing on prostate, but in terms of in regards to other cancer like breast, they have some funds whereby they have this I would say patient information desk, where whenever the patient who they are coming actually for treatment, they enroll them and they follow them up. That is not actually a unit which is part of the hospital. It's just like I would say like NGO. That's how they follow them up. But when it comes to prostate cancer or most of the malignancies, only breast cancer so far I've seen that they are doing their best in navigating their patient. But when it comes to other cancers, it's actually a huge challenge in terms like, for example, I was doing a retrospective study. I had to call, there was a lot of information missing in the electronic system, whether the patient is alive or what. So you have to call the patient, and you find that the majority of the patient, I would say like 80% of my patient passed away, and it was not documented. So those are the huge challenges we are facing. So most of oncologists is like, I'll just treat the patient, but following up is hard because I would say because maybe due to the doctor-patient ratio or healthcare provider ratio to have time of following this up patient. So I believe that in order to tackle this challenge, having a program which is independent, because some, like Kilimanjaro Christian Medical Center, they tried to use their social welfare office to try to follow up the patient, but implementation was really hard because the social welfare workers, they have to attend the hospital needs and then follow the cancer patient. So this is the challenge. So I believe by having a specific program only for patient navigation, and those navigators are not supposed to have by task, meaning that they have to work in the hospital and then have extra time, but they should be full-time following up this patient. So the so far challenges that we encounter is that we have a lot of missing data due to lack of patient navigation, and this is affects our statistics. We don't have solid statistics like, okay, we treat, how many patients are cured, how many patients are still alive. So I think if we solidify the navigation program, we'll have solid data, statistics, which will help us to improve our service and also improve patient care. I hope I've answered.
You have. Yes, I think it's a common problem when it comes to having designated staff who only do patient navigation work within the institutions or within the facilities. And you're outrightly, right to explain, or basically to give the analogy that once a program has funds to support patient navigation within the hospitals, then it is working. But if a program doesn't have funds, then there's no patient navigation to be done. And I think that also cuts across. We've encountered this in other programs that I've personally worked in, where they have patient navigators for cancer patients who are designated and paid to do that particular job. But to basically tie them down to say that if the funds are done, then there's no more work for patient navigation, and we have a lot of patients that are lost. So how do we go about having them integrated within the hospital system? And I think it is a big challenge to have designated patient navigators within the programs. And I think, as you've mentioned, with the social welfare or social workforce, to be able to do this particular part of that job, and also because of they have multiple roles within their job descriptions, then it becomes a bit difficult when it comes to a way forward for patient navigation. But I can try to tie this down to Dr. Zulu's presentation to understand when you're setting up this patient navigation program. You've mentioned about ideally navigators should be selected from local communities. Could you expound a bit more on that and how you implemented that project to have navigators be selected from local communities? And who are these navigators? Are they community health workers or community health volunteers? Or how are you able to identify or who would be doing the patient navigation job, Dr. Zulu?
So with us, we had a criteria for patient navigators. So for example, the criteria is men are more comfortable most of the time speaking to men. So that was the first criteria. The second criteria was that it needs to be someone that is retired or someone that can commit for at least 12 months. Whether it be maybe someone who's a student and needs to also gain some experience or some sort of internship, but there needs to be a commitment from the patient navigators. And then with us, due to funds, also fund limitations, we pay out stipends, and the stipends cover transport. So that is why we selected navigators within the community, because then it lowers or cuts down the cost of traveling to navigate patients within the system.
Okay, so that basically comes with a cost. So, or does it mean that these potential patient navigators are volunteers, or as you've mentioned that they're being selected? So, do they send in an application for this, or is it advertised, or do you just call out for volunteers to be patient navigators and they are trained to do this? So as you think around that, how has that been progressive in terms of patients not being lost to follow-up? And was that implementation as effective to have that group of people not having a so to speak, a medical background to be able to do this particular job? Or how was that criteria looked at?
So the first thing is, with us, we wanted the community to engage in our project. So, which is one of the reasons why we selected people from the community that people are familiar with. But before we selected them, we requested the community leaders, which is the chiefs, in Duna. I don't know the English word for it. Advisors, chief advisors. So the chief advisors to suggest people. Some have a healthcare background, some have social worker background for psychosocial support. So there is some sort of educational background in relation to either psychosocial support or healthcare. And then from there, since they're in the community, it makes the navigating more easier, and patients being lost within the system is limited, because if they find out so-and-so didn't attend session, they can now go back, because they stay within the same area, go and do a home visit and check why. And if maybe it's anything that they can refer resources to, then they do that. So that's how we limit patients getting lost, from using people that are within the community and that will be able on a daily basis go and check on patients should it be required.
Right. I think that's also one of the comments or thoughts that Edna Tembo on and said, any thoughts to engage the community navigators from civil society organizations, etc. I think you've also, Dr. Zulu explained the importance of engaging the community to be part of this process in terms of patient navigation for prostate cancer patients. And also at the same time, it's good, best practices to also, definitely involve the communities to be part of, creating awareness, and also at the same time reducing the stigma, and also being able to support people living with, prostate cancer within that particular part of the region. So maybe one more question here I can see as well is, using technology. Ronnie Obu Lemire, who basically asks, have you tried to utilize phone navigation to improve early diagnosis, treatment, and survivorship follow-ups? Probably that's also for Dr. Mwakipunda as well, and Dr. Zulu. Has the use of technology being a good tool to follow our patients, and also looking at improving diagnosis, treatment, survivorship, etc.? Either.
With this current or the previous project, we had access to funds. Therefore, we were able to provide navigators with tablets that they can use as a form of technology to monitor patients, to do capturing on. So it made the admin side of it more smoother. But we've had other patient navigation projects that are not specifically prostate cancer related, that have not had funds that were available to do that. And it was a bit tricky there.
Mm-hmm. Right. So, Dr. Makipunda, I think just to put it in context of a facility that that you're in, which is a public institution, you have probably limited resources. Does the hospital facility and the clinics also have a community approach towards follow-up of patients of this, looking at accessing cancer screening and treatment services for prostate cancer? How do you also bring about the engagement with patient organizations within your region? Has that been able to also support the patient navigation aspects within your facility?
Yes, it has, especially here at Ocean Road Cancer Institute. Of course, the use of technology is being used highly, even with a palliative care where they can navigate a lot, but it's not actually employed in terms of screening. There is a lot of information which is not documented using technology in terms of screening. Most of it is paperwork, I would say. But in terms of diagnosis or treatment, that is being done. But in terms of screening, it's really hard in terms of navigation, yeah. But it's actually possible if we want to, yeah, it's possible if we want to.
And looking at when it comes to patients who are being seen within the facility, at what stage would they be coming in to access treatment? Is it usually late stages or early stages? Because I think you've also mentioned in your presentation that we have a challenge when it comes to awareness in the communities around prostate cancer, or basically cancer in general, and what is the impact if, of course, because we know that lack of awareness means that people don't know, and that means people come into the facilities later. What stages do patients come in a bit, within the facilities, and is there a way to mitigate that barrier in terms of raising awareness in the communities, doing campaigns, just as Dr. Zulu has mentioned, doing, basically campaigns within the communities?
Yeah, majority of our patients, they come at late stage. Late stage in a sense, we kind of, used to that, which is not a good thing. Sometimes you find like you get a early stage patient and everyone like, is it really an early stage? It raises that doubt, having just that experience of daily having stage 4 cancer, stage 4 cancer. So whenever you see an early stage, everyone is like, you need to investigate further. We really doubt about it, you see. And yeah, of course, we have campaign program, and most of the campaign programs, they are institute-based. But for the Ocean Road, which is the National Cancer Institute, as I said earlier, they have this scheduled annual program where they go through the country. So they have the schedule every region where they do screening. But now, after screening, now that the navigation thing is being lost up, there's no further follow-up with the patient. But screening program is there throughout the country, which can help actually reduce late presentation. And again, I believe this thing is a continuous thing. because awareness, I was involved in for example, I was involved in Northern Tanzania program, screening program. So we actually did, the last time we did it was 2019, and then 2020 I was not around, but it was done. Since then, there's no awareness campaign. So we can't rely on the awareness campaign done, like I would say, like 3 years back. So it has to be a continuous thing, a community-based thing about educating the patient, because even the awareness sometimes is being done in a brief way. Some patients, they are even reluctant because they haven't received fully information about it. So my opinion, having regional-based awareness campaign will be better rather than waiting for the government funds for the National Cancer Institute to go around the country. If we have regional, maybe in Kenya you call it county, every like monthly having this awareness campaign, and where there's an open desk, whenever a community have question, they can go and ask about it. It will reduce the number of late presentation. Yeah.
Okay. Do we have any other questions I can see on the chat box? Yes, maybe just a comment here by, oh yes, let me see. I have Mishka, your hand is raised. Please proceed.
Yeah, thank you. Thank you for the great presentations. I think both of you have clearly made a very strong case for the need for patient navigation programs to exist and to be integrated. My question is, and you may not have the answer to this, but I'm curious if there's been done any kind of like a costing or investment case done based on the work you've shared. You described at Ocean Road in particular how you've invested in the diagnostic pathway, the treatment pathway, and you've had patients come through to a certain point and then you've lost them to follow-up. So the facility has invested in all of this work to care for a patient. And so if the facility has that knowledge of what that incremental cost would be to include a patient navigator on top of all the costs that it took to diagnose and treat the patient thus far, if that would be helpful to build that investment case so that the facility, whether or not it's working through volunteers or through paid navigators, I think that reliance on volunteers, while I think it's fantastic and community oriented, this is really, mainstream part of care, really, right? So, reliance on volunteers, it makes it very difficult to make it sustainable. But if it's able to be wrapped into the budget of at a facility level, I can't imagine that paying for a patient navigator costs as much as the machinery it takes to diagnose and treat patients. So I'm thinking that if that cost is, added, it's not as big the cost to losing the patient altogether. Over.
Yeah, hello. I totally agree. As the old saying goes, prevention is better than treatment. And so I think it's the priorities where it lies, because now the National Cancer Institute is being governed by the government. So it's all about the priorities. I don't know whether the hospital here has made a budget, because I'm a resident. My base hospital is at Kilimanjaro Christian Medical Center in the northern Tanzania. So I made this budget to know the budget of patient navigators. I don't know about it, but I'll try to speak about Kilimanjaro Christian Medical Center, where I come from. What I know, they try to make this navigation program just to have I don't know the exactly cost, what they mean, but they have tried. They said maybe by 2 years to come, they will have this navigation, patient navigation. So at least for Kilimanjaro, I know that they are in the process of having patient navigation, but for Ocean Road, I really don't know. So as you said, it's really important to have navigation, because it's actually, it will save a lot of money, as you said. And in terms of priority, I remember when I was involved in screening program, there are those patients who had insurance, and we ordered the quantitative PSA through their insurance. And the insurance company did not reimburse the investigation. And they say that the insurance company, they don't, and that's the national insurance. They say that they are not covering screening. So you can imagine, so I think it's a matter of priorities. We need to advocate for our patient and request the government to just weigh whether prevention and cure. So you can just imagine just a simple investigation, they didn't cover, but they cover a lot of unbelievable expensive chemotherapy. So I think it's just a matter of priorities. So we need to prioritize this patient navigation program. Yeah.
Yes, yes, I think you're definitely right. We are facing a challenge when it comes to patient navigation, and prioritizing that particular cadre, so to speak, that may be able to do that particular job. But you know, a lot of lobbying and a lot of discussions to county health, facility-based management teams, and either district or regional levels or county level leadership to have this in place. And I think it's quite an interesting discussion when it comes to, you know, who would do that particular job. And I think in Kenya, for example, not long ago, they have, you know, flagged off community health promoters. That's what they're called now. And before they were called community health volunteers. And I think that's one of the things that we are trying to understand would be, you know, what would be the way forward when it comes to having that group of people be able to do that job, you know, in terms of supporting screening, but screening, diagnosis, and also patients to follow up for treatment. There's one, let me just see. Yeah, we have one, a few more comments here. Raphael Koima basically mentions that navigation is so critical in assessing cancer screening and treatment services. Peer navigation, especially in cancer treatment centers, is just amazing. And then we have, yeah, I think Dr. Zulu was also reiterating that the organization basically has a volunteer department, and they recruit and train volunteers on cancer, and the department they wish to volunteer in, and this has assisted tremendously. We have more volunteers than staff, which is a great thing. And she would like to suggest that maybe other organizations and facilities consider using this model to assist with patient navigation. I always say that we are all advocates. We push the agendas within the communities and see how we can integrate the community aspects, of course, in raising awareness, which has also been highlighted by Dr. Makipunda, to see, you know, that way forward in terms of raising awareness and also trying to capture these patients at the early stages. And I think that's where we need to continue lobbying, because I think patient navigators are very, very crucial, especially in getting these cases a bit on the early stages. Do we have any more burning questions, any comments from the participants? Please, you could raise your hand or just unmute. Free. Or any hub team members who could comment on this? Okay, so probably just a general question for both Dr. Zulu and Dr. Mwakifunda is, when it comes to prostate cancer in general, and I think this cuts across in Africa, is to understand why not a lot of emphasis is put on prostate cancer. So is there like a stigma related issue around prostate cancer, or there's no, there's not enough noise being made within the communities about prostate cancer, or patients or people who may have or are suspected to have prostate cancer don't even know about prostate cancer? What is the feel on the ground in your countries when it comes to prostate cancer in general, when it comes to access, raising awareness, access to diagnostics, and also treatment and follow-up? Are patients also accessing the adequate medicines? Do the national health insurance funds or the insurances also cover this? Or what are the challenges that you're also facing when it comes to patient care?
Yeah, thank you. Yeah, the challenges are very vast, starting with the patient awareness. Majority of patients, the awareness is very little, especially when it comes to men in our community. Even you attend the cancer screening program, majority are women. Men, they actually don't believe, especially in modern treatment or going to the hospitals, stuff like those. So you find even at screening, majority are women coming for the screening. So it seems awareness is still little among our men. And even some cultural things. For example, this patient, the last case I presented, actually I had the time to talk to him. And I asked him, like, how comes you stay like 18 months before screening? He said, like, due to my age, I thought that this was just a normal thing. So you can find, you can see such kind of mindset. So it comes from awareness. And when it comes to diagnosis, again, I would say is another financial issues, constraints again the patient they're facing. Because now they have to see the urologist, which they have to pay consultation fees, and the prostate ultrasound, and those things you might find is another cost. And when it comes to treatment, of course, most of the treatment is being covered by the national health insurance. But again, majority of patients, again, they don't have health insurance. And so we say prostate cancer is like an elderly disease. So some patients, they say, I'm already old, I can die with this at home instead of all this cost maybe my family have to encounter. So you can find it's a lot of financial burden and awareness and all this in all this combination. Yeah.
Yes, Dr. Zulu?
For us, when we wanted to start the project and we were doing needs assessment, we went into our research archives, and there was a lot of research that shared that there is a huge stigma when it comes to prostate cancer, especially in rural areas. It's either there's a belief that someone is bewitched. Men prefer using alternative treatments, such as going to medicine men, before actually approaching health facilities. So there is a stigma around that. And yeah, the research shows that there's basically a lot of lack of knowledge within the community. So we saw that the problem starts within the community, which is why it's very important to have these awareness events and share knowledge and educate the public.
Right, and just to follow through with that, so cancer is it a government institution or is it non-profit? Is it an NGO?
It's an NGO. It's
Okay.
a non-profit.
So it's a non-profit NGO. So are you linked or tied to work with facilities within South Africa, or do you have an affiliation as well with the National Cancer Institute? I think that's also for us to understand the dynamics to see, in the case of Dr. Mwakipunda in Tanzania, if there's ways of collaborating with organizations who are doing something similar to like the project with cancer in South Africa. Maybe just learning the ropes of how a project can be identified and do a collaboration with an institution, but also at the same time have a means and ways of sustainability towards showing these institutions or facilities that adopting a similar model can be done within those institutions, so that we can reduce the mitigating the issues around prostate cancer. So do you have this form of collaboration, or do you work independently?
We have several collaborations. So currently I'm working on MOUs, Memorandum of Understanding or Agreements, with the different provincial departments of health. So for each province, we are getting into an agreement that cancer may work in their facility alongside them, a partnership of sorts. And I believe that partnership, because we have some provinces that have signed, those partnerships have benefited us a lot, because we had initially wanted to implement the project in a different province, and we had not signed an MOU as yet, and it was a challenge. And we ended up not implementing the project there, or we're not going to implement the current project there. But with KZN KwaZulu-Natal, we have an MOU, which then made it easier for us to approach the departments and say, look, we want to do this and this, and like basically patient navigation. And they came on board once we pitched the idea of patient navigation. Patient navigation is fairly new in South Africa, but I believe that if we continue, we can then provide evidence that it is needed. It should be a requirement. It should be in institutions or treatment facility. It should not just come from organizations that want to do projects, because once the funds run out, then it means that there's a possibility that the project may cease. But we've also considered other factors to make sure that even if we no longer receive funding, for example, from the American Cancer Society, we will still be able to continue partially with navigation, because I believe that we are all navigators without us being aware that we actually navigators, because we have the care home, which takes care of patients that are in far to reach areas, that transports them to and from the treatment facilities. That's already navigating. We have an information desk that is within the hospitals, within the hospitals that we've signed MOU agreements with, that is providing education and informing the public. So the project, even if funding ceases, we hope it doesn't, but in a way it will continue.
Right.
And with all of this, we're mainly using volunteers.
Right. I think while you were speaking, maybe the participants were also thinking around the same. Maybe a call to action regards to patient navigation being a very crucial aspect in terms of patient care or cancer care. and to see how we could, present a case, just as Mishka Kohli has mentioned, in regards of putting a case forward on a budget, so a justification to provide to facilities or your national cancer institutes in regards to the importance of having patient navigators. And I think where we usually fall short is to highlight or showcase it in a way that actually makes sense to the decision makers. And I think to put it in action to show, for example, these cases which have been presented by Dr. Mwakipunda, is that you do receive patients sometimes at later stages. There are issues around raising awareness in the communities, but also at the same time, we have patients lost to follow up as much as they come for treatment, and how to showcase this to project to decision makers or policy makers within reasoning as to why we are losing patients. And that patient navigation is crucial to ensure that we retain patients to receive the appropriate care and treatment within the facilities. And also at the same time that these facilities actually get income, so to speak, when patients are actually being seen in the clinics. So organizations or facilities are actually losing money, so to speak, when it comes to patient care, but also at the same time looking at patients who may have received care and treatment early in advance and not, have patients who are coming into the facilities at late stages, and also may have the risk of dying because they were not followed up when it comes to their treatments until they finished up their treatment. So I think those are some of the areas of interest in terms of thinking about a call to action within our own facilities or our national cancer institutes, to have that dialogue to see how can we incorporate patient navigators in the system. It's just the same way I can mention before around palliative care, which was also not really taken up. And I think there was a lot of dialogue in terms of palliative care and the importance of palliative care for cancer patients. And now palliative care has become quite a good area of interest in terms of the continuity of care for patients. So for patient navigation, I think it's also another way of call to action. One more question before I hand it over to Charles to do his last remarks is, Dr. Mwakipunda, I think I did see in your presentation, looking at the guidelines, the Tanzania guidelines, that routine screening is not recommended for prostate cancer screening. Has that been the case all along, or is that something that was just generally recommended by the Tanzania national guidelines, by the authorities on this?
Yeah, so the Tanzanian guidelines, they actually adapted from the National Comprehensive Cancer Network, which is the Americans. So it's actually, they extracted, I would say, the American guidelines to us. And the American guidelines is that they discourage routine screening of prostate cancer because there are some studies which have shown that screening, it led to over-treatment of prostate cancer. Because prostate cancer is actually a slow-growing disease, especially in Caucasians. And so for individuals to undergo screening, it leads to patient anxiety in terms of treatment. And so it has led to over-treatment. And those are the studies which are done in the US and Western countries. And also it has shown that from those studies that screening did not lower the rates of morbidity or mortality. That's why the NCCN guideline, they came up like screening routinely is not recommended. And so that's why the Tanzanian guideline is being adapted. But in what is the reality on our ground, should we actually not recommend? I think it's actually recommended. I think our genetic makeup is different maybe from the Western country, because the prostate cancer is actually aggressive in cancer when compared to Caucasians. So that's our guideline. I think at some point it needs a review, and we have to do studies. Like, really, we shouldn't recommend, or what? We have to do our studies on the ground in order to develop our own guideline. Yeah.
Okay, looking at the time, it's 6 minutes to the end of the session. Do we have any burning questions, comments? I think the participants have been very quiet today, and I'm sure they have a lot of thoughts in regards to this. Any specific comments? Oh, I think I see one thing here from Terry Mwanzi. I'm not so sure if I actually read this. So I think when it comes to prostate, there is less noise. The media too does less. When an organization plans for awareness and screening, few men show up. When the awareness is specifically for prostate, just a handful of men will show up. Also, how the screening is done should be communicated well. Since the information out here has made many men have fear. So I think it's another call to action as well, is to make men fear less and also be able to show up for screenings. And I think it's something that men need to really look into. I think there's also this notion that once you hit 40s, when you start getting to know your prostate cancer, PSA levels and so on and so forth. So there's still that mentality that, oh, I'll wait until I'm 40 before I get checked. But I think there has been a lot of talks and data to show that you can actually get screened way before 40. I think that routine screening is very important, but men need to really think around how best they can, raise awareness. And the same, we need more male champions to do this, but also at the same time, it's just to reduce this stigma. But it's one of those things. I know I'm a man myself, and I can always speak for myself, but yes, raising awareness for prostate cancer is very crucial, and I think it's very important to have that conversation. And I think Boniface here has really mentioned that men advocacy is a silent dinosaur, and we basically need to come up with strategies to change this. Yes, so one more person there. Great presentation. We're about to launch a navigation program, and this has been helpful. So prostate cancer in Zambia is on the rise because of stigma, and it's difficult to convince men. We need more male voices to reduce stigma. Yes, I think that's also a general overview to basically understand the issues around stigma, the issues around men, or basically in terms of health-seeking behaviors, men not basically going to their facilities for screening or just getting checked in general. So I think there's quite a lot of things there to understand. Okay, so I'll leave it here, but I'll just say that this has been a great conversation to understand the dynamics of patient navigation, access to patient care, screening, awareness, diagnostics, and also looking at how we could have this silent dinosaur be able to make a bit of noise. Dr. Mwakipunda and Dr. Zulu, thank you for your presentations. It was a great insight to understand the dynamics in Tanzania, and also on an NGO perspective in South Africa, and also trying to see how best we could collaborate and understand how we could create programs and also lobby to the government and our national cancer institutes to have the same. I'll leave it there and I'll hand it over to Charles Muya from KENCO to give his last remarks and ways forward for the next session. Thank you so much.
So thank you so much, Dr. Sam. And I would also wish to take this opportunity to thank our speakers for today, Dr. Leila and Dr. Nosifo. I think we have learned a lot from you, and we really appreciate you taking your time to share your knowledge and experiences with the community. So we are going to share this recording on Basecamp and also the speaker presentations. So in case you want to refer or to refer a colleague to the recordings who maybe was not able to attend, we will have that shared. So our next session will be held on December 14th. That will be a week before the scheduled time because of the holidays. And we are going to be looking at a very interesting topic, HIV/AIDS and cancers. And we are going to be sharing the agenda, the comprehensive agenda, which is still a work in progress. So once you get that, we would also request you to share the meeting link with your colleagues who would be interested in attending, so that we can all join together to share ideas around that. So I think that is it from the hub. I don't know whether my colleague Christine has anything to add before we close. Christine?
Sorry, I'm in a very nice place. Thank you, sir.
So thank you, and we wish you a good time and see you in the next session. Thank you. And bye.
Kwaheri.
Thank you.